So at this time, we are going to enter the closing part of our program, and I would like to introduce Ellen Edom from the Office of Public Health, Women's Health Department. Ellen.
Good late afternoon, everyone. So I'm Ellen Idem, the Director of the Office of Women's Health for the Department of Public Health. Thank you. Yes. Okay, it's now my introduce Dr. Debbie Allen. She's the Deputy Director of the Health Promotion Bureau in the Department of Public Health since 2017. She has a doctorate in maternal and child health and a master's degree in maternal child health and health policy from the Health Policy and Management from the Harvard University School of Public Health. And I'm not going to read all the awards. You can look at her bio. She's received numerous awards for her expertise. Dr. Allen has over 40 years of public health service. She's focused on the health of marginalized populations, including people with disabilities, children, including those with special needs. She has a profound commitment to fighting racism and sexism. She is an incredible leader, and she's my boss. So I'm introducing Dr. Debbie Allen.
Well, this has been just an amazing day. I feel, as Ellen said, I have 40 years in public health, and I feel that each decade there has been some really new insight that has made it very rewarding. I feel as if I've kept growing. And there were many insights that were sharpened by today's experience. I just want to highlight 4, and then I want to make a couple of comments about why we in the Department of Public Health see this so firmly as a public health issue and one to which healthcare in general needs to respond. So the 4 things that I'm walking away from and interested to hear what other people are walking away from are: 1, bodily autonomy is critical to human well-being. That whether it's in the form of imprisonment or lack of access to abortion or being subject to domestic violence, having the right to put a boundary around yourself where your skin is fundamental to human well-being. And wherever that violation occurs, there will be adverse outcomes for that person and for those who love them and to whom they are connected. So bodily autonomy. Second is that to address where bodily autonomy is threatened, we have to listen to the voice of those affected, that those voices and the voices of people secondarily who most closely serve those people have to be heard to shape the systems that are going to protect them. Third, I think, is that requires then translating that into policy and into programs requires collaboration, that there is none of those instances, whether it's, again, imprisonment or being affected by domestic violence, that one system alone can act upon, because there are always multiple social causes and factors that make people vulnerable and that also shape the infliction of those harms on people. So that we have to be ready the collaboration you've been talking about is key. And finally, and I think very poignantly in the workshop that I was in, that it costs. That there has to be, we have to be putting our money where our mouth is, where we're not the ones who own the money, we have to be fighting for the money. That you can't do any of this without resources, and that where our society puts its resources tells us what it cares about. Very basic. And we have to be fighting that it cares about the right things. And that goes back to the first point, that the right things is protecting people's bodily autonomy in the broadest sense of what that means. Their right not to be imprisoned, their right not to be violated in any other way. So that's my take home from the message. And then I want to offer you something that is sort of coming to you from a public health perspective, because I think it was taken for granted today, but it wasn't really fully fleshed out why we think of DV as a public health experience and as something that the health system has to respond to, although that's probably a little more clear. But really, when I think about what's a public health issue, I think about a couple of questions. One is, does it widely affect the health of populations? And it's very clear, I think, to everyone in the room that violence affects the person hit by the violence, right? That there is a victim, there is a person who survives the violence, hopefully, and they are affected, sometimes bodily. But there's also the community around them. And what we've learned, I do a lot of work looking at why there are such big differences between Black people in this country and other groups. We see this in LA around infant mortality. And infant mortality is really interesting because, you know, if you want to see how adults die, you have to look over a lifetime. If you want to see what affects babies, 9 months and you get an outcome. The baby lives or the baby dies. The baby is born full term or preterm. So it's a little bit like a laboratory, if you will, for seeing what social forces are doing to health. And after years of coming up with all kinds of other theories, sorry, my mask keeps slipping, what scientists have begun to really strongly conclude is that it's about stress, that there is a unique stress associated with racism, particularly as it affects Black people, that explains that difference. And one thing about DV that spreads beyond the immediate person experiencing the DV is that it causes women in general to be scared in so many different situations, to have toxic stress based on their experience walking down a dark street or going for a walk in the woods or having somebody come to the door, right? I mean, just think about the cumulative stress over time that our society experiences because there's so many of us who are afraid of so many others of us. So I think, and given what I said about stress causing infant mortality, that's taking a biological toll. If people experience toxic stress over and over and over again, cumulatively, it leads to hypertension, it leads to diabetes, it leads to all the things, by the way, that people died of when they got COVID and got sick. All the things that made certain communities especially vulnerable are the things that are caused by social stress, and violence throughout our communities is a cause of that social stress, including DV and including for people who are not directly affected by it. So that's number one. Violence is a strong predictor of health outcomes. The second that makes public health interested is it preventable? And we, you know, people may know that the Department of Public Health is home to the Office of Violence Prevention. And that office developed a strategic plan last year and did a lot of thinking about sort of what's our core strategy around violence. And one of the things we realized is that we have to communicate to people that violence, and I believe including DV, is preventable. That it's preventable both in the way we interact with the person who is going to experience it, whether it's in their high school, teaching them about what is and is not a healthy relationship, what are the things to watch out for, how to have a sense of their own future so that they believe they have choices and go out into the world insisting on those choices, through doctors who will talk to a woman when she comes in for care and realize that she is at risk of DV before the injury happened, before she's in the emergency room. So there's prevention around DV that affects the person who's going to experience it, but there's also prevention around the perpetrator. There's prevention about recognizing that trauma leads to trauma, and that that person has undoubtedly, in many cases, I believe, and I suspect many of you share this, had experiences of being traumatized themselves, of missed opportunities where the system could have identified them and could have intervened to give them other options in life. They could have been in that same high school class that talked about what's a healthy relationship and gave them a sense that being male, being an effective male, doesn't mean being a violent male, that that's not what that's about. So we believe that if we, and I think there's lots more thinking to be done about that, about what does prevention on the perpetrator side look like. And we are, as people know, home to the Domestic Violence Council. I think those are kinds of questions we'd like to see addressed. So I think there's, you know, that those 2 points, that it causes terrible health effects and that it's preventable, make DV something that we're going to worry about in public health. And we are thrilled about the opportunity to join with you in addressing it. The one other thing I want to say, I was just in a workshop where somebody who gave a great talk, but she said one thing, I don't know if she's still online. She said one thing that I think is an error, which is she said that the person who came up with the concept of social determinants of health was a fairly recent pediatrician. Some of you may have heard that. You probably all didn't catch that point because it probably doesn't mean as much to you as it does to me. Because the person who actually came up with the idea of the social determinants of health is a doctor who lived in the 19th century. And he's actually a pretty interesting character. I encourage you to Google him. His name was Virchow, Virchow. And if you Google Virchow sausage, you will get one of the very few public health jokes. You know, we're not generally a funny group, but Virchow was a pretty funny guy. And if you Google those two words, you'll get I promise you, you'll get a laugh. And if you want to catch me privately, I'll tell you what it was. But Virchow, as a medical student in, I don't know, the middle of the 19th century, was sent by the King of Prussia to go and look at why were miners in a certain part of his country dying so young. And, you know, he thought he was going to go and do a study of diseases. And he was blown away by what he saw about how the miners lived, how poor they were, how lousy their housing, everything you would expect of 19th century miners. And he came back to, you know, the capital of Prussia, I don't know what it was at the time, and was asked to write his report. And he wrote his long scholarly report. And the bottom line, he said at the end, is, what's his prescription for fixing the situation of miners? He said, give them the vote. And so we all have to remember that in addition to all the other things we have to do about dealing with best practices, you know, implementing all the best practices we've been hearing about today, really thinking about how we can make our own systems work better. Also to remember that part of our job as citizens, as well as people who are involved in ED or health, is to make sure our country follows a path that creates the conditions people need to live healthy lives. And that means taking very seriously what our voice means as public citizens. Virchow was right, we need the vote. So that is my final message to you. I'm thrilled to have been here and so glad to have shared the day with you.
Okay, can you hear me? We have now come to the end of our program, and on behalf of the Leadership Council for Domestic Violence in Healthcare, we want to thank Blue Shield of California Foundation, the Office of Women's Health, our amazing speakers, staff, vendors, exhibitors, Intangible Productions, and the California Endowment, and of course, our in-person and virtual audience. Please complete your evaluations. It is required to get CEUs. And if you're not getting CEUs, we just appreciate you completing it. It helps us improve our symposium each year.
And that concludes our third annual Beyond Silos conference. Thank you so much.